Alnoor, are you there?
I think
Can you
he
hear
is
me?
coming. He's here.
Okay, you.
Okay.
Very well.
There he is.
Excellent. Sorry, guys. I lost you on one computer, so I had to switch to another one.
Quite all right. It's 12 o'clock, and I think we should start. Welcome to Grand Rounds. It's a pleasure today to introduce two of the members of the Division of Gastroenterology, Dr. Alnoor Ramji and Dr. Hin Ko. If you look at their training, it's very similar, including their post-fellowship training in hepatology at the University of Toronto. So I'm pretty excited. This must be a very important topic because last week's Grand Round topic from VGH was about non-alcoholic fatty liver disease. So I'm assuming that there's a difference when we cross the river. So I'm really looking forward to this. So I guess Dr. Ramji is leading off. So Alnoor, please.
Thank you, Dr. Tessa. Thanks for the kind introduction. And thank you all of you for attending. So Dr. Ko and Hin and I are going to present on non-alcoholic fatty liver disease. And what was alluded to, and I hope you'll get from our presentation, that it's an increasingly important event in all our lives, particularly in our practices, hopefully not in our lives, rather in our practices, just based on the actual prevalence and potential for progression of liver disease and challenges associated with this. So we're going to discuss the who, how, and what to do. These are my disclosures for this and other liver aspects. So the objectives today are really to discuss the epidemiology of non-alcoholic fatty liver disease globally as well as in Canada, to review the natural history of NAFLD as well as NASH, understand the principles for evaluation of NAFLD. So those are the sections I'm going to go through. And then Hin is going to go through the management options for fatty liver disease to include lifestyle modifications, current and emergent therapies, as well as surgical options. So when we look at liver disease, what the commonality is the natural history of fibrosis. And you can see that it goes from minimal fibrosis, which is stage 1, to stage 4, which is cirrhosis. But what you should note as well is the distance between stage 1 and stage 2 is different between 2 and 3 and 3 and 4. So it's not a linear scale. Rather, it accumulates at a faster rate. Patients tend to be asymptomatic as well. I had this conversation yesterday. Most patients are asymptomatic with fatty liver disease or with most liver diseases. And therefore, we can't use symptoms as an adjunct or indication for necessarily initial evaluation or diagnostics. Most are asymptomatic. When we look at the spectrum of liver disease on the first section on the very left top, you see non-alcoholic fatty liver disease as steatosis. And essentially, you can see that they are just flat globules within the liver. And the next part is that it evolves into an inflammatory aspect. So you can see NASH, which occurs in 25% of patients who have steatosis. And you see little blue stuff in there. Whenever you see blue stuff on pathology, that's indicative of inflammation. So you get steatosis, which goes to inflammatory change, which is non-alcoholic steatohepatitis, so inflammation. And whenever you get inflammation, that begets fibrosis. So 20% of those patients with NASH end up having cirrhosis. And then when you get cirrhosis, obviously there's this risk of hepatocellular carcinoma. So looking at the global prevalence of fatty liver disease, something that, this is a very American aspect, there's high obesity, diabetes rate, this is all going to be US based. But the truth of the matter, it's a global epidemic. It really is. So when you look in North America, about 25% of persons, 25% of populations have steatosis or fatty liver disease. If you're going to South America, it's at 31%. And it's very interesting because there are some ethnicity data to show that different ethnicities are affected differently. And this may not be purely due to geographic lifestyle aspects, which is sometimes assumed. In Western Europe, it's very similar to us. As you go into the Middle East, the numbers go into about 32%. And then even if you look at Asia, there's very high chance of a very high prevalence of fatty liver disease at 27%. And really the African continent at 13% is a bit lower. And we do see that ethnicity, that signal that's a bit lower in persons of African heritage. If you were to take one slide, and I'm sure Hinin is going to tell you to take multiple slides home, but there's a couple of slides I really want you to take with you. And this is probably the most impactful when you look at your practices in internal medicine. These are predictors of advanced fibrosis in persons with non-alcoholic fatty liver disease. This is using the NHANES data set. And it's showing you the odds ratio for patients with advanced fibrosis. This is not showing you steatosis and bland NASH, as in minimal inflammation. This is showing you the odds ratio for advanced disease. So diabetes, our odds ratio of 18, obesity, odds ratio of 9, hypertension 1.2. And as persons get older, they will accumulate more fatty liver and potentially more fibrosis. So that accounts for the age signal. What about Canada? We think we're quite insulated with regards to not having as much obesity compared to our cousins. And in all reality, our obesity rates, and this is actually 2017 data, shows that approximately 40% in Canada are normal weight, 34% overweight, and 27% are obese. When we look at BC, so if you look at the map on the bottom, BC is 22% obesity. As you move into the prairies, it goes into the mid to high 30s. Ontario, Quebec, mid 20s. And then as you move on to the eastern seaboard, you see high 30s, mid 30s as obesity rates. And I just showed you what the implication really is of this. This is a modeling data set we did nationally to look at the prevalence of non-alcoholic fatty liver disease in Canada between 2019 and 2030. And I will say that it's modeling, making a number of assumptions. On the very left graph, you look at the prevalent cases of NAFLD and NASH, as well as F4 fibrosis. So NAFLD is projected to increase by 20%. So in 2030, you'll estimate over 9 million people have fatty liver disease. Prevalence of NASH, so that inflammatory component, which begets fibrosis, goes from 5% to 6.5%. And compensated cirrhosis will increase by 95% when you look at 2030. So significant increases, and probably a little bit more than Hinin and I can see. Let's go back to the NHANES data set, because the question really becomes as well, what proportion of your patients actually have steatosis by BMI in patients with and without diabetes? So when you're looking at different BMI portions, this is shown on the x-axis, and the proportion of patients in the y-axis, patients without diabetes in blue, and patients with diabetes in orange. So if you look at the first columns, BMI between 25 to 30, you see that diabetes is very strongly predicted, even in the overweight patient, to develop steatosis. As you go into the obesity range, so if you look at BMI 30 to 35, you can say that 70% more or less of your patients with diabetes have steatosis. So this is a signal of who needs to be evaluated who is overweight. Certainly, probably all the obese persons, but certainly if you're obese and diabetic, 70% have steatosis. And if it's BMI over 35, 90% actually have steatosis. Let's look at the same data set in a different view. And this is looking at moderate fibrosis. It's utilizing biomarkers, and we'll discuss how good biomarkers are. But looking at moderate fibrosis in patients who are overweight and obese, again, same things without diabetes in blue and with diabetes in orange. So if you're overweight, moderate fibrosis occurs in 25%. And similarly, if you're obese, it's about 25%. But if you're looking at extensive fibrosis, overweight patients with diabetes, about 10%, and a bit lower in patients who are obese and diabetic, just proportion-wise. But you can see that in your practice, about 25% of persons who have diabetes have at least F2 fibrosis, which is a staggering much. So a quarter of your patients have F2 fibrosis who are diabetic, whether they're overweight or obese. And if they don't have diabetes, they still have mid-teens to almost 20% of steatosis, of a significant fibrosis. Does it make a difference? Well, this shows you mortality as fibrosis changes. So this is based on meta-analysis, and I could show you probably a dozen studies with similar data sets. And mortality is shown on the y-axis, and fibrosis stage on the x-axis. Remember, zero fibrosis is no fibrosis. But you see this inflection point when you look at stage 2 fibrosis. So when you hit the stage 2 fibrosis, you can see the mortality rate, all-cause mortality actually goes up. And as you increase in hepatic fibrosis, overall mortality goes up. About 4 or 5 years ago, it was thought that predominantly this is all driven by cardiovascular signals. But now we find that liver-related mortality, this is data last year and a half, it is a stronger signal than actually cardiovascular is for many of these patients. When we look at liver-related mortality, it's quite obvious that as you increase fibrosis stage, your liver-related mortality is also going to go up. So the point you're going to take away from this, that any fibrosis is now a signal towards increased mortality. Now, this is absolutely fantastic data set. It's a bit busy, I know. So this is data from just last year. And what Sweden has is this amazing data set of patients who've had liver biopsies, and they managed to follow them over essentially 30 years. And they looked at patients with fatty liver disease and looking at their effect on mortality. So on y-axis, your cumulative events, on x-axis, the number of years. At the very bottom, that kind of orangish line, whatever color that is the population comparator, i.e. the reference. Simple steatosis. So just having steatosis without any inflammation, as you can see in the olive line, already has a signal towards mortality. The green line is NASH, so inflammation with no fibrosis. Again, mortality goes up. NASH with non-cirrhotic fibrosis, so say stage 2 fibrotics, which is in 25% of your obese patients with diabetes, signal on mortality. And obviously, if you're cirrhotic, that signal goes up significantly more. So what this very nicely shows us that even steatosis begins to become a signal towards increased mortality. You know, when you're doing CTU, when you're in medicine and otherwise, you know, you don't always realize how common fatty liver really is when you look at the proportions who develop cirrhosis. And we always think about alcohol and chronic hep C. But if you look at the proportion who develop cirrhosis from that, 25%. If you look at it in fatty liver disease, you see a very similar signal. So you can see that the actual prevalence is so much higher. Hep C is 1%. Fatty liver disease is 25%. So you can see what your practice is going to look like or what CTU could look like in the next decade or so. There is a thought, there's no need to diagnose NASH if there are no treatments. And certainly, Hinnen is going to completely refute this, but hopefully the data has already shown you that there is importance in trying to evaluate and diagnose NASH, because that is going to give you signals of mortality and how to optimize the patient's care. So that truly is wrong. We should try and evaluate patients, all persons, for fatty liver disease. The question really becomes who, and I've tried to do that. So it really depends what your goal is in all this. And I think we're too early for screening for fatty liver disease. But what I'd probably want to say is there should be case finding for fatty liver disease. So in context of case findings, we look at those patients who have risk factors. So if you look at the total population, fatty liver disease, say, occurs in about 25% of patients, NASH in about 5% of the patients, and then F3, F4 fibrosis in a smaller proportion. So what you probably want to do, because we can't possibly evaluate everybody, well, you can evaluate everybody, but you probably want to hone down into those patients with more significant signals towards mortality, is to evaluate fibrosis. So the evaluation of fatty liver disease and NASH it's much, much tougher than one would actually think. So just to look for bland steatosis, you could try and use an ultrasound. However, you know, it really, as your colleagues will tell you in radiology, there's less and less, not validation, but more so standardization of when a patient is thought to be steatotic. Because if you increase the range, you could see a brighter liver, which is indicative more of steatosis. Some ultrasounds will say severe steatosis, and often the patients are worried and the GP is worried, and you get an urgent referral for severe steatosis on an ultrasound, but that really is not really the case. So steatosis can be evaluated by ultrasound, not great. We can use the Fibro Scan for looking at the CAP score. Again, it's not a great evaluation. The role of liver enzymes really doesn't tell you about steatosis. It's more about inflammation more than anything else. So in all honesty, steatosis is very hard to evaluate when you're looking at bland steatosis. So what we have to do, at least in 2022, is look at fibrosis. And the mainstay is going to be non-invasive fibrosis. The bottom is the liver biopsy, but we're not going to biopsy 25% of the population. You want a tool that's easy, that is cheap, and you can utilize in every patient. And that's going to be probably biomarkers. So the two ones you're going to take away from this talk are really FIB4 and the NAFLD fibrosis score, which we'll go into a little bit. We do have vibration-controlled transient elastography. So Fibro Scan is used at our centers and many others. And then there's something called shear wave elastography. And essentially, this is done by radiology, not at our unit, but there are some, it's probably about 20 units across BC, where you can get an elastograph or a stiffness by simply changing the software on the ultrasound machine. So let's talk about different fibrosis evaluations. This shows the parameters needed for the NAFLD fibrosis score. So you have a patient's age, easy, AST, ALT, platelet count. You should be able to get the BMI fairly easily. You do need an extra blood work for the albumin and the diagnosis of impaired fasting glucose or diabetes. So NAFLD fibrosis score can be done. You just Google, like everything else in this world, you Google NAFLD fibrosis score, and you can get the calculation online, and you can see the AUROCs, which are pretty good there. And these are useful to try and find patients who have minimal fibrosis and ones who have moderate to extensive fibrosis, because that's what you really want to evaluate. Who could probably be weighted off for now with minimal to no fibrosis versus those with more advanced fibrosis. I like, and what we're trying to push nationally is really the FIB4 score. Where FIB4 score we have used in hepatitis C, and that's where it has been more validated, but there's increased validation in fatty liver disease. It's simple. You get the age, AST, ALT, and platelet count. When you use a Life Labs form, you actually have to ask for AST, which is critical because it's not thought to be, it sounds funny, a liver enzyme overall, so you have to ask for it specifically, but you need that for the calculation. You go to Google and it saves your life. In fatty liver disease, a score of 1.3 rules out advanced liver disease. In Hep C, that's 1.45. So we've changed the values a little bit to decrease it, and that actually improves to exclude patients with advanced liver disease. If a patient's over 2.67, there's a higher likelihood of advanced fibrosis. You get the middle ground, intermediate ground, which is a large proportion of patients. We probably would estimate about 25% of patients. And in that, you probably need another modality of evaluation. So this is the whole context of Googling. If you go and you look for FIB4, this is what you're going to get. In the blue part is your interpretation. And my only warning again is that this interpretation is based on Hep C, not on fatty liver disease. So ideally in this world, and I've tried to push for this a little bit, we've just not get the uptake yet, it is Life Labs or any of the labs when you, and I asked St. Paul's to this and again was shut down more or less, was to say that let's give you a FIB4 score for any patient in whom you get liver enzymes and if platelets is available. And because it'd be very useful, just like you get the GFR when you order a creatinine, you get a FIB4, and that takes one step away. We have to reduce barriers for these patients to enter care. So hopefully in the future, we'll be able to do that directly on the labs, or at least your EMRs can be set up to do something similar. So in our clinic, we're lucky we do have a Fibro Scan. So we use this in almost all our patients with fatty liver disease. It takes about 15 minutes or so. You put a probe by the right costal margin. It gives an elastographic wave. And then with this, you can tell the stage of fibrosis overall. Okay. And it's a very valuable tool in this sense. Again, the AUROC on its own is probably about 0.85, 0.9. But when you do it in combination with your FIB4, that increases it. And between these two tools, it's probably one of the best mechanisms, at least used globally. I'd say the US has MR elastography, which we don't have. So these are probably one of the best tools you get with ultrasound shear wave is very similar to this. So let's look at the model of care for patients with fatty liver disease. I pray that I've convinced you that all patients with diabetes and obesity at least should be assessed. There's probably lower signals in dyslipidemics, and they probably actually transverse the other two groups to some degree. Any patients with imaging showing liver disease or steatosis should be evaluated, and obviously anybody with an abnormal liver enzyme. And abnormal is just 1 point over normal. Dr. Casson would tell you that, males who have ALT over 30 and females ALT over 20 should be reviewed. And I would agree, but, let's be less purist and even just use what Life Labs tells us. And I think even with that, we're probably missing a lot of patients. So those are the patients I think should be reviewed without a question in the context of case finding. Where should it be done? I think any clinical setting is very applicable, whether it be primary care or specialty care. The only aspect that say you got to be mindful of is when they're admitted on CTU and they have a pneumonia and the liver enzymes go up, it is useless to get a FIB4. FIB4 is used for chronic liver disease, not for acute liver disease. So they come in with renal insufficiency and they're, hypovolemic, or they've had a GI bleed, the liver enzymes go up. I really don't care. That's nothing. You can't use the FIB4 and say, otherwise it'll all be cirrhotic. And so there has to be used essentially in the outpatient chronic setting as opposed to acute setting. So what do we do process-wise? I've driven you the FIB4 aspect. This is a model of care we're trying to push again. This is, again, nationally, but it'd be very good to uptake everywhere, obviously. First, we do the serum markers, use FIB4 or NAFLD fibrosis score. If a FIB4 is less than 1.3, you could probably monitor with the early biomarkers. If you felt uncomfortable, they should be further evaluated. If a FIB4 is greater than 1.3, they really need a secondary fibrosis evaluation, or if there's other risk or clinical judgment, anytime we feel uncomfortable, irregardless, they should probably have some further evaluation. So they should start from a FIB4 and then go on to elastography with Fibro Scan or shear wave. And those patients should be linked to multidisciplinary care. We're getting a dietitian in our group, and there's importance in context of lifestyle with Hinan is going to go through this potential for different modalities, and Hinan is going to go through this, but there's so much that could actually be done for this patient even today. But at least to inform the patient of where they are, to be able to follow them and provide the risks in the long term for the patient, I think is important to do. So summary for my section, really non-alcoholic fatty liver disease is very common, related to its risk factors. I'm asterixing obesity and triple asterixing type 2 diabetes because that's obviously important. Fibrosis is linked to mortality, and some of us would argue that any fibrosis, and certainly if you get stage 2 fibrosis, is linked to a mortality signal. Case finding for fatty liver disease, I think we are there. I really think we are there. The newer guidelines from Obesity Canada have small signals. Unfortunately, they don't have a strong signal for this. The diabetes guidelines, the American diabetes guidelines, provide the strongest signal. Evaluation for fatty liver disease is challenging. We have to rely, I think, on the stage of fibrosis as opposed to say who has steatosis or not, because that's very, very challenging to do. So thank you very much. And we'll take questions at the end, I think, Hinan, right?
Yeah. Mm-hmm.
Okay. And I'll let you carry on. Now I have to try and
stop
sharing. New share. Oh, poor share. Okay, hold on. I have to do this. Sorry, guys. Here. Oh, this is my last slide. To join CANASH. CANASH is our national group for non-alcoholic fatty liver disease. So if you're interested, please email out. Okay, Hinan, can you?
Yeah, I think I still cannot share quite yet. Okay, let's see. Yep. Okay, let me change to this view here. Okay, thank you, Alnoor, for giving a very good overview of the fatty liver disease and the diagnosis. Now I'm going to focus on the management of NAFLD and NASH, kind of as Dr. Ramji alluded to, that we really don't have any approved medical therapy. And quite often, and you've all probably heard about, diet and exercise currently the primary recommendations. But it's easy said than done. Many times we've just had patients try, not successful, and they might take our recommendation differently. For example, like someone say, oh, treat one slice of pizza. I can see here that it could be interpreted as a really big slice of pizza. So in terms of the guidelines, we focus on is lifestyle. It doesn't matter you look at the American, the European, or the Asian Pacific guidelines. The key thing is lifestyle modification involving dietary modifications, weight loss, and a very structural exercise interventions. I will go into each of them a little bit more detail in subsequent slides, but in general, the diet, we want to create like an energy deficit because you have to take less in order to lose weight. And then you have multiple trials before looking at different diets, and they all show probably like some improvements that can help together with exercise, help with the fatty liver. And I will mention particularly a little bit more about different diets later on. And weight loss, in general, about 7 to 10% of weight loss is the target we look for. And in order to really see some resolution of the inflammation in the liver and to regress some fibrosis in the liver if someone has some. Exercise on its own actually have been shown to reduce liver fat content. And but we need a combination of aerobic exercise and resistant training ideally. But again, you have to really tailor to the patient preference and what they can do. And lastly, when nothing helps, sometimes we might have to need a more invasive intervention like bariatric surgery, which I'll mention in a bit. Now, this gives you a slide about the lifestyle approach. It has to be very comprehensive. So as already mentioned that we want to limit the energy intake, so have to have some calorie restrictions. And the key is not just the short-term weight loss. We want to maintain the weight loss, like in order to maintain the benefits. Coffee definitely is good. And there are many studies to propose that like drinking coffee might be beneficial to slow down the fibrosis progressions. In terms about a diet composition, ideally want to be more low to moderate fat, low sugar for sure. And as Dr. Jayakuma mentioned the last grand round last week, fructose is being metabolized very differently from glucose in the liver and is more prone to lead to hepatic steatosis. So definitely we want patients to avoid fructose as much as possible. And the low carb diet is recommended. Alcohol intake also want to be minimal if possible. And physical activity, like roughly about 150 to 200 minutes per week, moderate intensity, and combination aerobic and resistant training. Now, this is a very important slide. I think this is probably the first slide I want to like take away is the percentage of weight loss, where it's based from. So many studies look at if you just want some improvement in terms of the degree of fat. So it's just aiming for steatosis improvement, looking at the bottom of the pyramid. So you need to aim for more than 3% of the weight loss. But if you start having more inflammation, if you had a liver biopsy showing ballooning and inflammations, you really need to aim for a higher amount of weight loss. So at least 5%. Now, as you go to the top of the pyramid, if someone really have fibrosis, which is not a permanent process, it's reversible, you really want to aim to lose about 10% of the weight loss in order to achieve fibrosis regressions. But you look at the right column, unfortunately, a higher percentage of weight loss we want to achieve, it's less likely the patient able to maintain their weight loss. So for example, less than 10% of the patient will be able to maintain a 10% weight loss at 1 year. So that's why we come across with the recommendation. We want patients to achieve 7 to 10% of the weight loss because we want some resolution of the NASH and fibrosis regressions. Now let's talk about exercise. So they have many trials you can see, and there are 28 randomized trials in this meta-analysis based on the exercise-based interventions. And this is actually, they take away from the diet components. So this is just exercise alone have been shown to reduce intrahepatic fat content. And they do very fancy calculation using this standardized mean difference. So what does it really mean by minus 0.69? So they basically, if anything over 0.5, you had a moderate to significant impact. So basically, exercise not just have a low impact, it definitely translate to a significant impact on reduction on the liver fat and also reduce the liver enzymes. And you can see on the side there that you can definitely see favoring the exercise. Of course, it's very hard to do exercise and diet study, and you have see a variation of the study design. So you don't expect to see a very high like odds ratio, but definitely see a significant impact from exercise, definitely beneficial in fatty liver disease. Now, diet, the one that get the most kind of support saying the benefits of this diet is the Mediterranean diet. So we want patients to try to have more fruits and vegetables, less carb, and more like the seafood, really minimal animal fats, like meat and sweet intake. And they find that you can kind of adopt this into different culture, but seems like one key element is you need to take some extra virgin olive oil, seems to be very essential. And you really want to have more omega-3 and omega-6 fatty acids and more fiber. Now, in terms about Mediterranean diet, is there any meta-analysis? So we do have one. This meta-analysis has made up of 7 observational study and 6 randomized control trial. And then they again see this diet is associated with significant improvement in the liver steatosis when they use this kind of MR spectroscopy, not by ultrasound, so a little bit more sensitive than ultrasound. They also see by using this diet, you expect to see a reduce in the BMI, triglycerides, and improvement in the insulin resistance, improvement in insulin sensitivity. And then also, but no significant effect on the waist circumference, cholesterol, and liver enzymes. So you see kind of like a trend favoring Mediterranean diet. Again, it's very hard to do a good Mediterranean diet, any diet study, because there's so many confounders. But again, it seems to be favorable trends when this fatty liver patients on a Mediterranean diet. Now, you also heard about patients asking for, oh, what about low carb diets, low fat diets? So we have some meta-analysis on low carb diets. So this is look at 10 kind of international clinical trials. Now, again, it's a bit, design is not consistent. Some study look at ALT improvement, some look at AST and GGT, and only 4 of the study look specifically at the fat content. And the low carb diet seems to be associated with significant reductions in the intrahepatic fat contents. So minus close to 12%. So we can see definitely some improvements. But again, you haven't really seen a significant reduction in liver enzymes. And they did an update meta-analysis, really find no difference between low carb or low fat diets. And also hard to tease out. When you do low carb diet, they probably lose some weight. Or it is just weight alone that's probably causing the improvement in the fatty liver. Now, what about intermittent fasting? I got asked a lot more recently from many patients, and there's also different kinds of doing intermittent fasting. Some people do 5 days of normal diet, and then on the weekend do a or just 2 days of the week do a very restricted intake. And some do more like a time restricted eating. They will eat over 16 hours and then have 8 hours fasting, or like vice versa, or even like 8 hours condensed eating and prolonged fasting. So there's 6 studies doing this meta-analysis. The 4 of them were more religion-related fasting. So you can tell, it's probably a lot of confounders. It's not like the perfect meta-analysis. 2 were randomized controls trials. So again, we see a trend that intermittent fasting show a benefit on weight loss and the improvement of liver functions, but really no significant benefits on other metabolism-related parameters like cholesterol, triglyceride levels. Now, what about, do we have any pharmacological agents available at this time? So have to go back to this study that had been published like 12 years ago. So we do have some agents that currently have some benefits, but they all target of insulin resistance. So kind of like borrow some of the drugs that were used to treat diabetes. So this is the Prevalence study published in New England in 2010 and look at pioglitazone and vitamin E in NASH patients. So this is the patient that have biopsy proof of NASH, but they don't have any diabetes or cirrhosis. So as you can see, in terms about the y-axis, patient with improvement, and the x-axis is the different endpoint they look at, like whether resolution of the NASH, improvement of the steatosis to fibrosis. You can see that compared to placebo, definitely see improvement with vitamin E and pioglitazone. And not surprisingly, fibrosis is very hard to reverse. So you definitely expect to see kind of lower percentage improvement. But despite that, you see some trend, but there's no statistically significance between placebo and the interventions. But again, it points out a signal that, potentially vitamin E and pioglitazone could be a good agent to use in certain NASH patients. So subsequently, there are more studies to look at the effects of vitamin E in NAFLD. So they look at the NASH activity score. So it's a histology scoring system, like they have scored allotted to ballooning, inflammations, and the steatosis. So they look at this meta-analysis over 1,000 patients with NAFLD. So you can see on the left here, is you kind of see any improvement in fibrosis. You definitely see kind of slight favorable trend towards vitamin E. And also the NAFLD activity score, you also see patients taking vitamin E seem to do a little bit better with lower score. But again, there's some limitation. There's some quite variable definition of NAFLD used in all these trials. And some of them have small sample size. It seems to suggest that maybe vitamin E is an option for certain obese patients. between age 15 to 50 had a bit of elevated liver enzymes. If they take around 400 to 800 IU a day and lost some weight, seem to show some benefits. What about pioglitazone? We definitely use it in diabetic patients, but what about in those patients with fatty liver without diabetes? So there's 8 studies included in this systematic review and meta-analysis. Now, there's like majority, like 6 of the trials are on pioglitazone. Only 2 is on rosiglitazone. So majority of the benefit you see here is accounted by pioglitazone. So like you can see versus a control, again, you see a favorable trend towards pioglitazone to say that it has shown improvement in the advanced in NAFLD patient with some fibrosis. So what about in those patients with pre-diabetes and early diabetes and also fatty liver? So this is look at 18 months. So it's not very long, but after they have 18 months, they look at the patients to see whether like they rebiopsy to see whether there's some improvement in the NASH activity score, whether any resolution of NASH or improvement at least in 1 point in the fibrosis. So compared to placebo, using at the standardized dose of 45 milligrams, that you see that clearly it shows some benefit, that clearly more patients with the interventions had shown improvement in the resolution of NASH and improvement in fibrosis. Now we have to keep that in mind about the safety. So vitamin E, there's some potential possible all-cause mortality, but not confirmed. There's some signal. Also, there's some signal about hemorrhagic stroke risk and increased prostate cancer risk. There might be only selected patient you might want to consider, even though it's a supplement that you maybe not want to prescribe to everyone. What about pioglitazone? Again, even from the previous meta-analysis, people gain weight. So at least 3% of the people gain weight and they develop lower leg edema. There's also some signal about the risk of osteoporosis in women on pioglitazone and also maybe signal about bladder cancer risk. So again, not ideal, but so far those 2 agents available, if someone in need, you have to very carefully select whether those patients weighing the risk and benefits, will they benefit from these 2 kind of agents. Now, luckily, we know more and more about NASH, the different pathway. This is rather than like a single hit, it's multiple hits and many pathways involved in the pathogenesis of NASH. So we have pathway focused on metabolic. We have some insulin resistance pathway contributing to the increased steatosis in the liver. And also there's some anti-inflammatory pathway, and maybe eventually now we know all the pathway that allow all the research to target the different pathways. So eventually I anticipate there will be drugs that we need to maybe target one pathway for some patient, but some patient might need more than like 2 agents or 3 agents combination therapy to treat the NASH in the future. Another way to think about it is to put them in kind of buckets to talk about the process. So the agents are a bit small in letters in red are currently in phase 3. So we have agents that target specifically to insulin resistant and lipid metabolism. We have semaglutide, which is Ozempic, and then we use it in diabetic patients. And I'm going to mention about the THR later on, the thyroid hormone receptor beta agonist. And then we also have agents that really target on the lipotoxicity and kind of antioxidative effects. So we have some PBAR agonists and FXR agonists. Then later on, hopefully in the future, we have more new drugs go into phase 3, target more on the inflammation, the fibrosis pathway. So the first agent is something we had available, is the liraglutide. It's a GLP-1, it's more short acting, you have to use daily in overweight patient with NASH. So keep that in mind, this is a phase 2 study. So compared to placebo, liraglutide that you inject sub-Q daily clearly shows, compared to placebo, an improvement in histology. So for example, on the left, you see NASH resolution without worsening of any scar tissue in the liver. And with this medication, that's why indicated for weight loss purposes, it's definitely lose significant amount of weight compared to placebo. And subsequently, as expected, that liver enzyme also improved compared to placebo. Now, more and more data have been published about semaglutide in recent conferences. So this is a longer acting GLP-1, the glucagon-like peptide 1 receptor agonist. So you only do it once a week. So as you can see, rather than helping just the liver to reduce lipogenesis, decrease steatosis, It comes with other beneficial effects in the pancreas and insulin biosynthesis. Some cardioprotective maybe benefits. So it's more than just liver. Ideally, we do want drugs because many of patients, as Dr. Ramji mentioned, have diabetes, potential heart disease. So we're able to have agents that help more than the liver. That would be great. So this semaglutide study is published in New England last year. So the primary endpoint, they evaluate at 72 weeks. They have a pre-study biopsy, liver biopsy, and also after end of study, they also do a biopsy. So definitely it's a randomized double-blind multi-center trials looking at someone who's overweight, BMI over 25, and biopsy-proven NASH. So they look at 3 doses of the semaglutide, ranging from 0.1 to 0.4 milligram versus placebo. As you can see that even with the 0.1 milligram, you can see the odds ratio benefit compared to placebo is 3.36. If you use a higher dose, you expect to lose more weight. So the odds ratio benefit is like 6.87. So clearly this patient have NASH resolution without any fibrosis worsening. What I find more interesting is to look at how many of them actually show the fibrosis improvement. So again, it highlights that fibrosis is a reversible process. So you just focus on the pie graph on the left, the placebo. So the dark blue is showing the improvement. So 1/3 in placebo arm still shows some improvement. But again, close to 30% has worsening of the fibrosis at the end of the study. If you look all the way to the right in semaglutide, 0.4 milligram, you can see that 43% of patients had improvement in fibrosis, and then more than 1/3 has no change, and only maybe 5% of worsening. So you can see a clear difference that they actually improve, sometimes no change, but the worsening one is much less than someone who's on the placebo arm. Now, moving a little bit more exciting field about what about the emerging treatment options for NASH? Do we have any? So obricholic acid is an FXR agonist. Currently, it's available. We use it as for PBC patient, primary biliary cholangitis patient who don't have adequate response to ursodiol. So it acts on the FXR, this receptor in the liver, but we also have this receptor in our bowel, in the small bowel, especially in the TI. It's multiple mechanism. It helps to improve glucose tolerance, decrease fat production in the liver, also have some role in affecting the bile acids, and also some anti-fibrotic effects. So again, it just have some kind of multiple pathway beneficial effects. So the study they use is the Regenerate trials. So looking at 18 months. So again, it's fairly long enough, but probably may not be too long for some of the fatty liver to see a significant improvement. It's a randomized placebo-controlled phase 3 trials. Again, look at patients with biopsy-proven NASH with at least F2 to 3 fibrosis. It's a decent number, it's close to 1,000 patients. So the primary endpoint is looking for fibrosis improvement for more than one stage. So they look at 2 dosage. One is at 25 milligram, and the other one is 10 milligram versus placebo. So you can see there's some statistically significant, definitely improvement in terms of fibrosis. If the more you do, the higher dose. Now, in perspective, currently the dosage we use for other liver conditions is only like 10 milligrams, 5 to 10 milligrams. So this is used at a much higher dose than the PBC populations. So if you look at the right as well, the NASH resolution, again, you see a higher percentage of patients on the intervention arm show improvement or resolution of the NASH. Now, but there's a key safety signal need to mention. Compared to placebo, especially the 25 milligram, the higher dose arm, they have the one leading to discontinuation of the drugs is 13% versus 6%. So it's double the number of patients on placebo. And the most common and kind of serious adverse event is the pruritus. So you can see in the 25 milligram arm, like 51% patients will experience pruritus. And there's some other GI side effects. And also we see a signal of a little bit higher LDL, but so far this doesn't have translate into any clinical significance. So keep in mind there's some serious adverse event we need to consider. Most of the time, the pruritus, if you titrate well, interpret from the PBC patients, do a slow, titrate up slowly, then most of the patients can tolerate and can increase up to the dose we want them to be. But some of them clearly just have severe pruritus that they cannot be on these medications. So moving on is the selective thyroid hormone receptor beta agonist. So currently this is in study, but it looks very promising from the recent liver conference. So mechanism of action that we do have this receptor in the liver. So if you bind them, you definitely increase fatty acid metabolism by mitochondrial oxidations. It also helps to moderate cholesterol synthesis and metabolism. But keep in mind, it's very selective. It doesn't work on the alpha receptor, so you won't have the hyperthyroid side effects. So, I mean, it also help to reduce cholesterol, so also have some beneficial, maybe beyond the like extrahepatic benefits if you use these medications. So this is published in Lancet in 2019. It's after 12 weeks. It's to look at some patients with biopsy-proven NASH. They all of them had hepatic fat fractions over 10%. So how do they detect it? They use an MRI, so it's pretty sensitive to detect the degree of fat in the liver. So they basically look at the change of the fat. So in people taking resmetirom, so this is the THR beta agonist, definitely show less like improvement. So minus 33% in the change compared to placebo, only minus like around 10%. So further on recently, in the last year, the liver meeting, so they present more long-term data. This is at week 52 weeks. Not just look at the improvement in the fat content. We really want to know the ultimate endpoint is, can we really improve the fibrosis? So in the top here, the MRE means like MR elastography, similar to what Dr. Ramji mentioned about the shear wave elastography. We're using the MRI to measure the stiffness, and you know about the Fibro Scan. So on the left graph here is the MRI, PDFF, and the CAP. So it shows that doesn't matter which modality you use the MRI or the CAP parameter from the Fibro Scan, you definitely see improvement. So close to 50% improved, like minus a percentage change, a decrease in the fat. Now also, if you look at the kilopascal, the stiffness, the middle graph on the top, definitely, for example, VCT is same as Fibro Scan. They have at least -2 improvement in the stiffness measurement, and also improvement seen in the MR as well. And also in terms of percentage change, you see less than 20% fibrosis, and then 10% is noted on the MRI. And definitely when they on these treatments, they see improvement in all parameters, all the liver enzyme improve. And what's really impressive, if you look at the right here, the lipids panel, all of them show improvement, change from baseline about the LDL level get lower, apolipoprotein level got better, and even the lipoprotein A level, which is another kind of new now marker for some cardiovascular disease, all show improvement by giving them the resmetirom. So again, there's a potential extrahepatic benefits using this selective THR beta agonist. Now, there's some patient that no drugs can help, that we might have to think about more invasive intervention, the bariatric surgery. Now, the first trial we published was like back in 2015. It's a prospective study looking at morbidly obese patients, rated BMI over 40, and they have more than one comorbidity factor for more than 5 years. So after they have the bariatric surgery, after 1 year, 85% have resolution in terms of the NASH, the inflammation, and almost 34% has some fibrosis reduction. Subsequently, in 2018, there's a meta-analysis looking at some cohort study, and close to 3,000 biopsies they look at. And you can see the percentage of patients with resolution of the different NAFLD components like steatosis, inflammation, ballooning, and fibrosis, at least over 50% improvements. And only like 12% has some worsening of the NAFLD. Now, in 2020, the same group have published the first study. Now they have, like, again, more longer term data. So now looking at 5 years post-surgery. So you have 84% of the patient NASH resolution with no worsening of fibrosis. So what's very interesting is the graph on the right. So at baseline, you can see more people is in the darker kind of red and orange bar. So that means they have at least F2 to 4 fibrosis. Again, if we introduce intervention, the bariatric surgery, the weight loss, you can see more people have fibrosis regressions in the more like lighter kind of like orange between like now F0 to F1. And to the left, as expected, patients who have big, like larger amount of weight loss, so more BMI, so you can expect to see higher percentage of resolution of the NASH. So that's why leading to the guidelines about bariatric surgery, it is an option for patients who don't respond to life change or any pharmacotherapy we have so far. Even patients with compensated mean NASH cirrhosis, we can consider bariatric surgery, but it have to be case by case because we worry we don't want them to have decompensation because it's not like a minor surgery, and they should be referred to an experienced bariatric surgery program. And then, unfortunately, some patients, by the time we meet them, they kind of like maybe even have decompensations or end-stage liver disease. And currently, liver transplant is indicated for this NASH cirrhotic patients. So if you consider referring them early for liver transplant assessment, and with the kind of more people nowadays with fatty liver, we anticipate that we may be one of the top, we probably already top one of the reasons for liver transplant. It may even surpass Hep C or alcohol, become the top reason for liver transplant down the road if we kind of still waiting for good pharmacotherapy agents. So in summary, we know that NAFLD and NASH are very common in very clinical practice in primary care, in other like endocrine clinic or cardiology clinic. It's not benign, even patients feel nothing, and NASH is the progressive form. It's just difficult sometimes to diagnose. We currently have some non-invasive tests that can help us to triage some patients, as Dr. Ramji mentioned, maybe FIB4, the MMS, and then if someone had high risk based on the non-invasive tests, can consider refer for Fibro Scan or the shear wave or the MR elastography. But currently, we really don't have any approved medications. The primary recommendation is still, key thing is weight loss. But we need a combination of dietary modifications and exercise in order to maintain some NASH resolutions and fibrosis improvements. But exciting field, there are more and more new drug regimens being developed, and hopefully we will have something coming to the market very soon that we can offer to our patients. So this concludes I think our talk, and we're open for any questions.
I think there's a couple of questions box, and I'm just going to go there. Can you get OCA approval for NASH through pharmacare?
At this point, no. So far, just only indicated for the PBC. They filed to the FDA, but they want more like a stronger endpoint. So the company had been kind of getting more evidence, maybe more long-term data. So the short answer is currently no, we cannot get pharmacare approved for this indication.
So I have two questions. First is the clinical question. Of all of the therapies, of all these studies, I'm assuming that weight loss, the lifestyle modifications were all in place for the patients that underwent the studies with different pharmacologic agents. Is that correct?
Yeah, they try to standardize as much as possible, but very hard to study. You're right. I think when patients even involved in the study, they got more close follow-up, they probably pay more attention. I think there's some kind of a ground. They try to correct the confounders about any, it's due to a dietary change, not that much. So I think some of the benefit is from the drugs, but there's some factors I don't think you can really control in a study setting. The patient do get more attention, and even the placebo. Sometimes that's why you see a high placebo rate. I think just because patients now in trial, they're more aware of this diagnosis and maybe doing something extra on their own. That's explain why the placebo rate sometimes you see some improvement.
And a follow-up question to that, and this is really my ignorance, but I always thought fibrosis was a permanent situation. But you've shown, and how do they judge that fibrosis actually resolved?
Yeah, so from we know from fatty liver, even in hepatitis B, this way I think we first know fibrosis do improve. They did biopsy after someone on treatment. We actually see we have histology to show, wow, this is after treatment and even before treatment, they definitely see that the fibrosis has improved. And so similarly for the NASH patient, now all the clinical trials, they do need liver biopsy before and after. So definitely they have readers to make sure that more than one reader look at the biopsy to show that the fibrosis do, some do improve, of course some don't, but definitely it's based on the histology that it does happen if you're able to control whatever insulting factor to the liver. Okay,
so there's a follow-up question. Sorry, these are in the chat box. Metabolic associated fatty liver disease, NAFLD, was recently proposed by International Consensus Panel. Is NAFLD interchangeable with NALFD? And in the NAFLD biopsy, pathologists routinely report the grade of inflammation. Do you manage your patients based on the grade of inflammation?
So, I think MAFLD will take over NAFLD because NAFLD is a lot more negative connotation. You want to exclude alcohol, obviously. Are we there completely yet? Probably not, but I think it's when it's going to meetings now, MAFLD is more or less accepted. So I think over the next couple of years, certainly MAFLD will be there. And I think it actually encapsulates the overall diagnosis a bit better. With regards to pathology, routinely we don't biopsy all our patients unless they're really for clinical trials. It's not frequent. Would I use the inflammatory grade? Probably not as much, at least at this point. It would help to serve mostly in the context of clinical trials, again, when you're looking for steatohepatitis improvement, as opposed to routine clinical care.
Okay, thank you. Any other questions? So another question on my part, of all of these modalities, independent of the diet and exercise, and I don't mean to lessen those importance, but in your practices, in patients that don't have a comorbid situation, such as diabetes, how many of your patients would you have on these different pharmacotherapies? Maybe Hin first.
Mm-hmm. Yeah,
so what's a baseline of how many patients you would have that you?
Yeah, so if someone really don't have diabetes, at this point, I haven't really put them on specific agents. Like even I know this one note asked about vitamin E. I mean, if someone non-diabetic, pretty healthy, otherwise no cardiac risk or prostate cancer risk, I worry I might put just vitamin E maybe, but not consistently. But I wouldn't be prescribing just like semaglutide, for example, for them, if just for fatty liver. I would try to aim to more make sure that diets, they talk to dietitian and the exercise, see if they can do some weight loss by that. But if they have some really significant like weight issues, sometimes I do encourage to talk to like some like internists or someone interested in weight loss. Then maybe they will benefit from agent more specifically to help with the weight loss. But at this point, I know even as I think for example, the semaglutide, keep picking on that one, you do need like a special authority to coverage to even if they fail certain diabetic medication, maybe before they can go on. So personally, I have not put them on any pharmacotherapy agents. Yeah,
Alnoor?
So I've used vitamin E historically. I haven't used it in the recent past. I am impressed with the GLP agonists and weight loss. And, there's clearly a signal when you get to that 10-13% weight loss, which is achievable with the GLPs. And if that's sustained, that you can get some regression of inflammation and fibrosis. So in my majority of patients, I'll try and sway them towards clinical trials because, there's probably more, it's more robust in the context of evaluation and endpoints. In those patients who could not be there or whatever reason they don't decide and they're obese but not diabetic, that's I think where you may say, would I try a GLP agonist for obesity because it's not a label for NASH? And even that it's challenging to get, as Inin said, you're looking at 3 months essentially, which is an assistance program from the company, as opposed to approvals, right? We don't have that in Canada yet. So that would be a trial. And I think they may just get that reduction and then hopefully maintain it. But it's also clear that once you stop those agents, they just bounce up. And that's why these clinical trials are 3 to 5 years in range, as opposed to 6 months or a year, because that's really not enough.
And there's one final question here. What do you recommend to those with low BMIs, particularly Asian background, which seem to have a high prevalence of non-alcoholic liver disease?
Yeah, it's tricky. We call them the lean NAFLD because honestly, look at them. I cannot ask them to lose weight. But I think always when you get to go over the diet, quite often, maybe I'm Asian, I can say, I think there's some improvement in terms of diet. So I told them maybe not focus on the weight per se, but we still want them to stay active. I think all of us including myself, not doing enough exercise. So I did say, yeah, try to really stay active, change the metabolism, and then cut down some carbs. I still say I'm not really worried about the number because you always will be normal BMI, even using the Asian BMI cutoff. But I would say by doing those two, I do think there's some improvement in the metabolism in the body. And I still see some improvement in terms of the fatty liver. But it's tricky. You're right. Those weight loss is not what we're looking for. It just, they already maybe even sometimes underweight or quite normal weight.
The fructose, how important in your, because you've mentioned diet, what do you tell patients to avoid?
Oh, yeah. I ideally, I say it should be minimal to none. So, I mean, the fruit sugar is okay. But anything with no white sugar added, no soft drinks. I've asked them to read the label a little bit more. So even many stuff they had sugar added to it, like cereals, they had sugar added to it. So I was you really have to read the label, avoid the sugar, that part. So as much as possible, it's just bad for fatty liver. So no juice, no fruit juice, but natural fruit is okay. But still, if someone have weight issue or diabetes, I tell them avoid those high sugar fruit like watermelon. Berries are okay, and maybe cut down the potatoes, those ones. So yeah, I mean, I will then kind of suggest maybe if they want more information. Still, I'm not doing a good job to say talk to a dietitian. They can definitely help them with more advice about a balanced diet.
I mean, sugar is clearly
Sorry.
evil. Yes, I was just going to say sugar is clearly evil. And I think that's, people underestimate how much sugar they consume. And, you want them to have a reasonable lifestyle and enjoy things, but at the same time not indulge, which tends to be what's happening most.
So thank you both for very, I didn't think there would be a follow-up grand rounds to the previous grand round, but I have to admit that I think you touched on areas a little differently, and I appreciated both. So thank you both very much. I wanted just to let everybody know next week's grand round is it's going to be presented by Dr. Rod Knight, who's part of the Division of Addiction Medicine, and his topic is addressing drug and sexual related harms among sexual and gender minority people. So that's next week. Thank you again, everybody. Have a good week.
Thank you. Have a great day.
Thank you. Thank you.